Ready?
Sounds good, yeah.
All right, good afternoon, everybody. It's our 2 o'clock session, and we're going to start with COPD from Dr. Steele. Dr. Steele, it's all yours, sir.
All right, hey everybody. Today we're going to be talking about COPD. I've talked about this to you guys a couple years, over the past couple years, and I've updated the slides a little bit to hopefully make some of the equations that I'm going to share a little more palatable. Because COPD really doesn't have, it has an extensive depth of treatment and understanding, but at the same time in your guys' role in the emergency medical service and even in the emergency department, we're treating the acute decompensation of the respiratory failure secondary to these COPD exacerbations. So we'll kind of focus on that a little bit and some of the other nuance you guys don't really need to pay attention to, but I always like to start and introduce myself. This is my family. It's my wife Nikki and my son Wyatt. I like fishing. I used to be in the Army. I was an infantryman for 10 years. I like beer, mushrooms, bees, all that good stuff. So overview, we'll just go over the anatomy, the mechanisms of respiration, which is really important, and even it's just a good fundamental to have down, which is why I covered it. Then we'll cover actually what COPD is, and then acute exacerbations and management. But first, since I'm an former anatomy researcher, I like anatomy. So these are cadaveric specimens of a cadaveric lung. And you can see just kind of the gross features of it. There's the apex at the top, the upper lobe, which I guess is going to be a little hard because you guys can't see my pointers, but you can see the fissures of the right lung versus the left lung. You have 3 lobes on the right, 2 lobes on the left, and then you have that lingula, which is the remnant of that old 3rd lobe. You can see the different pulmonary ligaments. The diaphragm surface on that top right is where the diaphragm cups in and kind of forms the lungs into that apex. And you can see how there's different sides to it. There's a narrow side and a more wide side, and that narrow side fits down closer to the mediastinum, whereas the wide side fits more anteriorly. And even on the top right, you can see where there's the groove for the aortic arch, left pulmonary artery, and some pulmonary veins. So you can see the connection of the lungs to the cardiac system is extremely intimate. Obviously, cardiopulmonary goes together all the time for that exact reason. In your guys' line of work, penetrating injuries to the chest this is an extremely vascular area, and so obviously in setting a COPD, you're not necessarily worried about penetrating injuries, but and bleeding, but it's something to definitely consider when you have other types of injuries to the chest wall, just to the nature and the connection to the great vessels of the heart. The next, just kind of covering a little more overview of the cardiopulmonary system, just showing the dynamics of where the heart lays and the intricacies, a little bit of the vena cavas, which are the feeder systems to the right side of the heart, into the right atrium, into the right ventricle, which goes out into the pulmonary arteries. The arteries go away to the lung, and then the veins come back to the heart. And the veins return in the left atrium, go to the left ventricle, and then out subsequently through the aorta and the rest of the great vessels of the arch and the lower abdomen there. On the right side, you can see a cadaveric specimen of the lungs partially retracted with exposure to the mediastinum and the removal of the cardiac capsule there. So you can see the picture of the heart directly. So 15, label 15 there in the bottom right labels that epicardium. It's just like it's basically a bag for around the heart. And yes, I said bag. That's why I meant something. Don't make fun of me. My nurses do. Hurts my feelings. And so again, I just want to really hammer the point home of this area of the body. I think it's good to see just anatomy in general. You can see the diaphragm right in the middle there and how high that moves up. So that's something to keep in mind when you guys are putting in needle decompressions, especially mid-axillary, that you're not penetrating into the liver, even though it might seem like you're still into the thoracic cavity. You can see how easily you can do that, and it's definitely mistakes like that have happened before on the doctor side and the first responder side. So it's an easy mistake to do. But that's why I just wanted to illustrate this anatomy a little bit more. And again, there's another picture of the lungs. And when we talk about COPD itself, COPD is constellation of different diseases that create an overall obstructive effect to the lungs. But many times you'll see these types of images here, which these are pulmonary edema, and you have COPD, you have the bulla forming, and you can see just how destructive that can be to the lung tissue. So I just wanted to illustrate some of the visual changes that we see on X-ray versus the CT scan, and then back to normal anatomy there. So the main bronchial airways break down from the trachea to the right and left main bronchus, and then to the subsequent smaller tracheal branches going through the rest of the brachial tree, smaller until it gets to the alveoli, which, if you guys remember from physiology and anatomy, it's the gas exchange interface. And the reason I'm talking about that is I want to show how many segments break out. So you can see it goes from 1 tube to 2 tubes to a bunch of tubes, and each segment corresponds to a respiratory area of the lung, which is the colored areas in the lung. So you can see different pathways aerate different areas of the lungs, which is important again for COPD. You start knocking out some of these small airways, you start getting shunting of the blood away from these areas of respiration. And again, this is a cadaveric colored visualization of these segments in person. So you can see from here, that top right colored view, to what it actually looks like in the real world. It's not quite as clean and separate, and that's due to anatomic variation, which is in everybody. So even though we're looking at these basic structured anatomy, people's anatomy can be different, but they tend to be very common in these conserved organs like the lung and the heart and the kidneys and all that, but you can still have variations. These are what these airways look like eroded, or not eroded, but dissected out. You can see kind of complex anatomy in there of those main airways, and all the tissue that's been removed is actual respiration tissue. So that tissue that is being removed is all the way down to the alveolar level. And when you're dissecting these, it's very much a spongy, very fine spongy tissue. So again, I just want to emphasize trachea to bronchi, to bronchioles, terminal bronchioles, respiratory, the alveolar ducts, and the alveolar sacs. And the reason I'm illustrating this is because in pathophysiology of COPD, you're going to have disruption of these airways, which causes physiologic issues that you're going to address with steroids, bronchodilators, etc. So this is what it looks like down to the alveolar level, which is the gas interface and gas exchange level. You can see on the top right, it's an electron micrograph of kind of a main airway with those smaller, it looks like spongy tissue, or it looks like a sponge. Those are those alveolar sacs on the right side, and those are thin single-celled wall, which is illustrated on the histology slide down on the bottom right, where you can see a red blood cell in there, and then I think there's some type 1 pneumocytes. There's different types of cells that kind of patrol the lung, and then the type 2 pneumocytes make the surfactant, or the lubricant for the lung, so it allows it to open up and expand. Now, on the bottom left there, you can see more of a colored illustration about how fine those capillary networks go down. So again, I'm going back to penetrating injury, but you can see any penetrating injury to the lung tissue is going to cause massive bleeding. Just because the nature of the lung tissue, it has to get down to that fine microcapillary level in order to exchange gas. In order for us to actually respirate and breathe, it has to function. So our alveolar sacs and our alveolar gas exchange are extremely, extremely important. And there's a reason I'm hammering on this, is because in emphysematous COPD, that's one of the features that gets destroyed, is those small alveolar sacs, thus inhibiting respiratory issues and all that.
Let me ask you a question.
Yeah, absolutely.
Seems to get easily confused. Every once in a while you just see someone, the light bulb goes off in them, you know.
Mm-hmm.
And maybe it's not necessarily your COPD lecture, but pneumonia is a lung tissue disease.
Absolutely.
And that's the tissue you're talking about that
Same
was
tissue.
removed in a couple of slides ago.
Yep. Which you get the shunting, you get similar effects to it. You get avoidance of the blood from that area, you get consolidate. Basically the body tends to, just with physiologic mechanisms, say, well, actually this area is not respirating, so I'm going to shunt blood from this area of the lung into more vital tissues. But you're right. So in pneumonia, you're going to have consolidation, or I'm using air quotes here. But what does a consolidation mean? A consolidation is really a collection of fluid, mucus, cell debris, bacterium, white blood cells, within those alveolar spaces that allows us to see that visually. So
Okay.
yeah, no, it's a good question. That's exactly the interface. And then a bronchitis or more of a bigger airway disease is in these bronchioles. So kind of
Translation of
bigger
of
airways
the
there.
actual airways
Yeah.
there.
absolutely.
So pneumonia's not in the airways because it's in the tissue.
It's in the tissue itself.
But it
Yeah.
can leak into the.
Yeah. Well, that's not to say
It's
there
that
aren't some.
consolidation you're talking about. Okay.
Exactly, and that's not to say with a pneumonia type process you won't have, you know, a massive pneumonia will involve the big airways and small
Okay,
airways too.
right, okay.
So like when I'm in the ICU and we bronch people with mucus plugs, and we'll see collapse of dependent atelectasis or collapse of the lung tissue because these big airways get plugged up with mucus, especially in pneumonia. They're trying to expectorate and clear all of that. And what it does is it actually just soaks up all the air and kind of collapses it because it doesn't need to use that tissue because it goes back to the same, you know, physiologic principles of getting it blood to good areas of lung tissue. So,
Yeah, okay.
but once you kind of remove it from those remove that mucus from those airways, that tissue tends to respond really well. So, but good question.
Okay.
So mechanisms of respiration. Ooh, math.
Oh my.
You guys became EMS, first responders, the baddest of the bad, to do math, right?
No.
No. This is a resounding no. And surprisingly, I didn't go to med school to do math. But unfortunately, unfortunately, I mean, if you understand the physics of something, it makes, and you can apply it to the body, it makes the understanding of the principles of the disease a lot easier. And so I'm going to go through this, and I don't want you necessarily to focus on the equations. That's not the point. I want you to see the equations, and if you have a basic understanding of math, you understand fractions and raised powers and stuff like that. But the point is more of the effect of the equation and what happens in COPD. So I'm just going to kind of read off this little blurb because I really liked it. But so respiration involves several key mechanisms that are impacted by COPD, and one important concept is Pessoy's law, which tells us that resistance to airflow is inversely proportional to the fourth power of the airway radius. What does that mean? All that means is that when you narrow down the airway, it has to the fourth power effect of it. So meaning it's not a 1-to-1 direct ratio. You narrow down that airway a little bit, it's going to have a massive effect on the resistance, which is the work of the movement of air through. So that's one principle, right? Pessoy's law tells us resistance to airflow is inversely proportional to the fourth power of the radius of the diameter. So going back to these small airways, that's where this comes into play. So what does that mean? It's just like you have a large radius, low pressure. It's like a hose over there, right?
Yeah.
That's Pessoy's law. We've all used physics, whether we know it or not, as a kid. You know, we make the water go farther by capping off the end because we narrow down the radius, which increases the resistance, which builds up pressure, and then subsequently allows it to go further. And that's really the only point of this. So look at this. So if on the top right it says the original flow rate, so it's 100 centimeters cubed per second. So a little 1 cubic centimeter per second of air, and if you double the length, you get 50 centimeters cubed. Double the viscosity, double the pressure. You see pressure changes, right? Pressure's on top there, but if you double the radius, it has a massive effect on volume and flow rate there. So this Pessoy's law explains how fluid or air flows through a tube, like air through your airways. Like I was saying earlier, the most important part of the law is that the smaller the tube gets, the harder it is for air to flow through it. So in fact, even small reductions in size of the tube make it much harder for air to get through, like squeezing a straw, right? Sucking up through a narrow straw. In COPD, the airways get narrow because of the inflammation, mucus, and damage to the lung tissue. And according to Pessoy's law, as the airway narrows, the resistance to the airflow increases dramatically, meaning it takes a lot more work, because what is driving this power? It's your diaphragm, right? So it takes a lot more effort for the person to breathe in and out. So it's physically harder for them to breathe, which is part of the reason why emphysematous patients are cachectic or so skinny. It's because they're literally using all that energy to respirate.
They're exercising all the time.
Exactly. And so, and I like analogies. So I included this year some analogies, hopefully that you guys kind of remember. You can see how this equation cancels out and breaks down a little bit, where it's mostly concerned about, just radius and length in this scenario. But imagine drinking a milkshake, like in not that one, what's that one movie? He goes, I have a milkshake and you have a milkshake. You remember that?
Oh yeah, I can't think of that name.
Oh God, it's that oil movie. There Will Be Blood.
Oh, okay.
Right? Yeah. Okay. So imagine you have a milkshake through a regular straw. It's pretty easy to drink up, right? So now if you imagine trying to drink the same milkshake through a coffee stirrer, right? Huge difference. Huge difference. You can hardly even do it. The milkshake doesn't change, but the narrower the straw, it makes it harder to suck up the milkshake. So in COPD, the airways are like those tiny straws, making it harder to force air through and air into it, causing difficulty breathing.
Yep.
So again, Pessoy's law in action here. Here's an example of a bronchiole, which is another feature of COPD, is this main airway inflammation. So not only can you have destruction of the alveoli, you can also have the airway inflammation, increased mucus, and there's a whole science actually behind the hypertrophy of the muscle in the bronchiole, because this is a dynamic system here. And they're targeting a lot of drugs against that hypertrophy now. So they're starting to go after kind of the root mechanisms of COPD in the drug world. So, another equation. I know we love equations. So this is called the Bernoulli equation. All right. So we learned Pessoy's equation, which is narrowing the airway resistance. It's harder, right? So Bernoulli equation can be considered more of a kind of conversation about conservation of energy for flowing fluids. Meaning that you're starting with a certain amount, you're ending with a certain amount. But what happens if we change the features of that travel like narrowing, right? What does it do to the velocity? What does it do to the pressure of the system? And we'll talk about that. So respiration involves several key mechanisms that, again, are impacted by COPD. One is the Pessoy equation that we covered, but the second one is the Bernoulli principle, which helps explain why COPD patients experience dynamic airway collapse. It's a big feature of COPD. So not only chronic obstructive pulmonary disease, this is where the obstructive portion of COPD comes into play, is the Bernoulli equation. It's because as you insult these airways, you basically cause a dynamic collapse, and that's explained through this equation. So as airflow speeds up in narrowed airways, so not only Pessoy's equation is saying not only is it harder, you have more resistance, but now the Bernoulli equation is saying that when it's narrow, as airflow speeds up in the narrow airways, the pressure inside it drops. I know it's kind of a hard principle to think, but if you have
Increased internal pressure.
yeah, so there's and I'll show you here in a second. So as the airflow increases through a narrow tube, the pressure that the air it has itself is much less because it's traveling faster. When air is moving slower, it has much greater pressure against the airway, and I'm pushing my hands out right here. And that's where you get a collapse of the airway. So that's where you get air trapping, right? That's why we say COPDers, that's why they purse their lips.
Yeah.
So they have to have some type of resistance to maintain the patency of these airways.
Yeah.
It's a natural mechanism. Tripoding is the same way. It puts them forward, puts them in a more aggressive position to support those airways and kind of naturally valsalva themselves. But then you see, like I said, the pursed lips is a key feature. So that's the Bernoulli equation. So as the airway narrows, the pressure of the air inside the airway is lower, thus it allows the airway to collapse. So we got Pessoy's equation with resistance, we got Bernoulli's equation with collapse. Okay, so in COPD, damaged lung tissues lead to higher compliance, so it means the lungs can inflate easier, but we have trouble deflating. And part of the trouble deflating is this air trapping inside. And that's part of the reason why COPDers say they feel like they can't exhale all the way. Mm-hmm. So, let's see here, this next equation, so, yeah, I'm trying to think of a good, I was trying to pull, so this diagram here, it might not, okay. So as this is my lame attempt at doing animations on PowerPoint. So, on that bottom one, so that big diameter, this is all consistent amount of fluid traveling through, right? It's constant. So it's traveling the same amount, so the volume that's starting in the tube has to get pushed through the narrowed tubes, right? It has to get, because it's not escaping anywhere else. So in that instance, one of the compensations of the equations explained by Bernoulli was that the pressure of the fluid in that tube is much less in the narrowing because the velocity increases. It doesn't have as much time to push against the wall. There you go. See, that was impressive. Oh man! All right. Gotta quit my day job here. So, and then one last part of this is compliance. So compliance is essentially, the easiest analogy is blowing up a balloon, right? If you have a really thick rubber balloon, it's hard as heck to blow up. But if you have a really thin rubber balloon, it's pretty easy to blow up. That's compliance in a nutshell. It's the elastic property of the lung tissue, and the results come from, that result comes from like collagen and elastin, and that's all these like in a mesh network, so it kind of stretches and pulls back together. So there's a natural compliance of the lung. Whenever you inflate it, it wants to collapse. And that's overcome by surfactant, that's overcome by your diaphragm, and can be then increased or changed with lung diseases, right? That changes the nature of the tissue. So in something like fibrosis, somebody that has interstitial fibrosis, their compliance is extremely high. It's high resistance in order to inflate their lungs to a similar volume as somebody without fibrosis. Whereas COPD, that can be changed. Oftentimes it's increased, the compliance is increased, meaning that it's harder to do the work from the air trapping, the firmness of the lungs, the fibrosis, and all that. How are we doing on time? We're good. Okay. So, in terms of lungs, it's just pressure and volume is how we measure compliance. So as the curve shifts to the right, compliance is decreased. And if you look at it, it means it takes more pressure to get to the same volume, is essentially all it's saying, if you read that graph.
Yeah, makes sense. That's good. Oh, okay. Oh, there's your balloon thing.
There's the balloons. So it's really that simple. Emphysema has a higher compliance, meaning it takes less pressure to get the same amount of volume, versus fibrosis takes more pressure to get less volume. So the other part of this too is lung volumes, when we talk about lung volumes. So obviously as air passes through the nose into the mouth and the further airways, warm, humidified, filtered, and it goes down into your lungs. But your lungs aren't just all available for breathing, right? There's tidal volume, which is that middle portion. That's usually about 500 mils, and that's important when you guys are setting up ventilators and all that. We use ideal body weight for tidal volume. Expiratory reserve volume is the amount of air you can push out after a normal breath. The residual volume is the air that can't be exchanged, so it's the air that's left inside your lung tissue. And the inspiratory reserve volume is that air that you can breathe in on top of a normal breath. You can see how that kind of comes into play. And this is important in COPD because your lung volumes change. And lung volumes are measured by spirometry. Literally, it's as simple as breathe into a tube of water, and it records it as it turns. So lung capacity, it's a sum of more of two lung volumes: vital capacity, total lung capacity, inspiratory capacity, and functional residual capacity. All those are really important for this, but I just wanted to illustrate here that we consider volumes of the lung different in different disease pathologies. And in COPD, you can see that there's going to be a change because the alveolar sacs change, and there's destruction. So let me get the exact numbers here. Yeah, I don't want to spend too much time on this slide. I'll remove that for next year. So Again, it's just another nice illustration. Normal air sacs, normal alveolar sacs, and then damaged sacs. And we're getting a Pessui's equation, Bernoulli's equation, we're changing lung compliance, we're changing all of these things for normal. The whole point of this, the whole point of me drilling all this crap for 30 minutes to you guys is to understand that COPD messes with very fundamental principles of how the lungs function in itself. So COPDers are pretty fragile because the lungs are obviously a vital, extremely vital organ. You need them. As you can see, there's reduced inspiratory capacity. You have increased functional residual capacity because you're trapping air. So that means you don't have as much functional air to exchange, but you're just trapping this dead space air. That's the only point I wanted to illustrate there. And then lastly, shunting. It's kind of a principle I've hit on a few times. We call this VQs. We get VQ scans when we can't give somebody a pulmonary embolism study. It's a nuclear radiograph study that allows us to look at literally this principle. Is the blood being shunted in the lungs? Basically, can we pick up radiographic evidence that it's being shunted? And that's our VQ scan. And we can say, oh yeah, there's probably a PE there, if I can't CTA somebody. So my point with this is a healthy VQ for an entire lung is 0.8. This changes with COPD. You guys don't really need to understand the numbers necessarily, but airway obstruction is a common cause of a shunt. And a shunt's an important principle, which I'll get into in a second, but the whole point of this is you have ventilation, meaning air exchange. You have perfusion, meaning gas exchange. Literally think about it as simple as that little teardrop shape on the top right there and a tube underneath. You have blood, oxygenated blood on one side, deoxygenated blood on the other, with the idea that the oxygen goes up to the alveoli and comes out as CO2. When you're changing the airways, when you're destroying the alveolar sacs, you destroy the ventilation portion of this. When you start destroying the alveolar sacs, you also destroy the perfusion portion of this. So you see, you're hitting this at two different spots here. And there's a range. So the top of our lungs ventilate a lot better than the bottom of our lungs. And that's all I really wanted to cover was just giving you a light touch. So so we went through all this crap. Like, what does it all mean? Okay, COPD, emphysematous changes, obstructive changes, destroying the lung tissue, trapping air, having a hard time getting it out, have a hard time getting it in. You're not exchanging gases efficiently, so all that adds up into somebody who's going to retain by CO2. So they're going to become hypercarbic. They're going to have a higher level than you or I normally live, just because of the nature that they can't physically get out their CO2, and that's the result of these alveolar sacs being destroyed. So the basics, it's a common, COPD by definition is a common respiratory condition characterized by cough, dyspnea, airflow limitation, and about 10% of individuals age 40 or older have COPD, which is quite a bit, and how many times, especially in the winter, do we get COPD calls? It's consistently ranked amongst the top cause of death in the United States, kills more than 120,000 people a year. Prior to COVID, it was the third leading cause worldwide of death, and it has a high consequence, or as a consequence of its high prevalence, chronicity, it's a high resource utilization. So it's frequent office visits, frequent hospitalizations. I mean, how many times do we deliver the same people over and over and over and over again? It is a high cost disease, so that's why it's important to at least have a good understanding of it. So establishing a correct diagnosis of COPD is pretty important, but you guys, if they're coughing, if they're having respiratory difficulty and they're hypoxic and they're a smoker, you can probably safely assume they have COPD, even if they're adamant and the blue in the face. Not, well, maybe literally, but telling you not. Funny. So people with obstructive lung disease have shortness of breath because it's as simple as it's hard for them to exhale all the air from their lungs. And because of the damage to their lungs and narrowing the airways inside the lungs, the exhaled air comes out more slowly than it should, comes at the end of a full exhalation, and air lingers in the lungs. Common causes of COPD, right? Emphysema, which is its own disease. Emphysema is the airway destruction of these small sacs. So it has its own name. It's called emphysema. chronic bronchitis. Going back to this. Oops. Going back to these big airways here. Right here, bronchitis, chronic bronchitis, narrowing of the airways, right? We already talked about all this stuff. So emphysema, chronic bronchitis, and lastly, asthma. Asthma is an airway disease that can cause COPD. I've seen many patients with it. Another disease called bronchiectasis can cause it, which is actually dilation of the large airways and destruction of the large airways into the fine parenchymal tissue. Cystic fibrosis, which is a mucus problem essentially. And that's about it. When we consider COPD, we consider asthma, emphysema, bronchitis, kind of to be the big ones, and then we consider bronchiectasis, cystic fibrosis. I don't see a bunch of cystic fibrosis. I've seen a couple patients with it, but they're usually in the same boat as COPDers who act like they've smoked all their life, or somebody with extremely bad asthma. It's the same disease progression. So COPD being the heterogeneous lung condition characterized by chronic respiratory symptoms due to abnormalities of the airway that can cause persistent, often progressive airflow obstruction. That's COPD in a nutshell. So again, we're talking about this again. Airways, chronic inflammation, mucus production, fibrosis, narrowing and loss of the small airways, and collapse of the airways. The lung parenchyma, meaning the actual lung tissue, that's the functional part of the lung, is getting destroyed. Pulmonary vascular gets changed, smooth muscle changes. All of this changes to that cardiopulmonary, and there's a reason I put that anatomy early on, is because not only does this affect the lungs, it affects the heart as well. And if it's starting to affect the heart, it's going to affect the kidneys. And you can see how this sequela of disease starts to occur now in somebody who's probably not compliant. I have a bias against many COPDers. I think we all do, and you're like, man, you're still smoking, you're still doing this, you're not going to your appointments, and for a COPDer to do well, they have to be a very reliable, compliant patient. They just do, and unfortunately, we don't have that. So bronchitis is that airway inflammation. You can see a histologic change in the right. Emphysema, you can see those pockets starting to form there in the bottom right. Asthma. So this is what emphysema looks like on CT. You'll see these small blebs on the right. Obviously, this is massive bullous. This is called bullous emphysema, where there are these. It's literally looks like a pneumo. You can see it's just all air. I actually had a patient a couple nights ago with a massive empyema, which is an abscess in the chest, with this bullous emphysema, and basically we called about 6 places and nobody would touch him. So it's like, it can get bad. It complicates things. Basically, once your lungs are at this level, you're kind of up the creek a little bit. We don't need to worry about that. So back to those lung volumes. This slide should probably have been placed back a few slides, but an obstructive pattern of disease, right? We talked about COPD, the disease, and then the the causes of it: asthma, emphysema, bronchitis. So an obstructive disease is what we're talking about with COPD. You can ignore the restrictive pattern; that's more fibrosis. With an obstructive pattern, you have a decreased or normal forced vital capacity, which is the total expiration of all your air in your lungs. Your forced expiratory volume, the amount of air you can get out in 1 second, decreases because of air trapping, and total lung capacity is normal or increased. This is a really good cadaveric specimen of this surface blebs. Basically, you can see the capsule of the lung around here, and you can just see all those emphysematous blebs. Those can spontaneously rupture. I've got a couple patients with pneumos from that. But yeah, you can just see how destructive it is, and you can see why you start trapping air. You can see why you're not able to respirate very well. Mm-hmm. Classification systems, you guys don't need to worry about that. I don't know why I left that in. So here's what's important for you guys. So onset of new signs and symptoms. Obviously cyanotic, you need oxygen, you can't breathe, you're gonna start treating that. Altered mental status, it could be hypercarbonic, right? Hypercapnia. Increased CO2 in the blood causes altered mental status. It's one of our differentials when we have an altered mental status patient, especially if they're a COPD and they're kind of encephalopathic and they're not really with it. I'm like, oh, what's their CO2? oh, it's 110. Well, where do they normally live? Oh, 80? Okay, well, that's still really high, whereas most of us live in that, 35 and 40 range. You'll notice an increase in intensity of symptoms, so increased difficulty breathing, increased oxygen requirements, increased mucus production, increased cough, right? It's all of those baseline symptoms that they have increase or getting worse. Signs of respiratory stress, accessory muscle use, paradoxical chest wall movements, both. You can have both features of that. And then serious comorbidities. So on top of this, then we can have all the other crap that can occur to lung tissues. This is just the basic disease. We're talking about just the basic disease of COPD. Not only can you have just COPD, you can also have heart problems with it. You have diabetes on top of it, renal failure, liver failure, pneumonia, all these other things that we talked about on top of COPD, or an empyema, like I just said, which basically is a terminal sentence, and that's because nobody will drain it because of how dangerous it is. You know what I mean? It's that big. It's that big of a deal. So. You can have hemodynamic instability, insufficient home support. There's lots of reasons as to why people have COPD exacerbations. A lot of times it's, temperature change seems to be a common one. The viral prevalence of upper respiratory infections within a community seems to be one. And then sometimes I just don't know. I can't explain why all of a sudden I'm getting 20 COPDers in. Is it pollen count? Is it what's going on? Is it bad batch albuterol? I don't know.
Storm season.
Yeah. So the too long didn't read of this. Significant dyspnea with one or more of the following: cyanosis or SpO2 less than 88%. Remember, these guys live about 88 to 92 is okay. They can be in that range. I'm not freaking out if they're at 88% on arrival. Now, if they're 15 liters, that may be different. But accessory muscle use, paradoxical chest wall movements, deteriorated mental status change, hypercapnia. There's a little equation we use to treat this. You don't have to worry about it. But for you guys, what do we do, right? So what do you guys have in the truck? You got steroids, you got beta blockers, or you got beta agonists. I mean, not beta. Well, you have beta blockers too, but beta agonists, right? And you have airway steroids, right? So we give Duonym. Duonym's ipratropium and albuterol, right? One of those is a steroid or an anticholinergic. The other one is a beta agonist, and in combination with that, with Decadron or Solumedrol, whatever you decide to give, which there's some nuance in that, and I like Decadron, and Solumedrol seems to work based on what I've read in the literature, pretty equivocal. All three of those are how you treat this. And why is that? Well, it's everything that we just talked about: airway narrowing, air trapping. If all these things, if I can help the airways get bigger, I decrease the resistance, I decrease the air trapping, I increase ventilation perfusion. So these are all the cascade of things that I'm thinking about when how I treat a patient with COPD. Now, most of my COPD patients right away, they're going to get the standard Duonym breathing treatment, anywhere from 3 mils to 9 mils for an hour long or shorter. The ipratropium, which is an anticholinergic, decreases, acts as a bronchodilator. It also decreases an anti-mucus agent as well. And then, oral glucocorticoid therapy for overall systemic inflammatory decrease, as well as obviously targeting the lungs. And then supporting them with non-invasive pressure ventilation is one option. So if they start to decompensate, you can support them with non-invasive means if you have BiPAP in the truck. Obviously not a breather, de-escalate appropriately. And then we always treat with antibiotics, and there's literature that shows that you see how many Z-packs are given out for COPD exacerbation. Well, there's a reason. There's a partial inflammatory reduction with this particular antibiotic, but also there's some good data to show that it may help decrease the prevalence of pneumonia, but I'd have to read up on that again. It's still up in the air, but you'll see most the common practice of physicians is to treat COPD, and I think that's what the gold standard is still. Like if you're going up to date and some of these, that's the gold standard still. So it's beta agonists, it's anticholinergic agents, and it's steroids, and that's what you guys have on the truck, and that makes a huge difference. Time to steroid makes a huge difference in this pathway. Same things with kids with you pick up a kid with really bad bronchiolitis or croup or something, right? Just that whooping cough. That steroid is the money. The steroid is what gets me that airway inflammation decrease, especially. So I have no problem with you guys performing performing these medical therapies for these COPD patients. In fact, it helps. It helps their time to recovery too. So, lots of different bugs: Haemophilus, Moraxella, Strep pneumo is kind of the more common one, but Haemophilus as well, and then Pseudomonas. And these are the antibiotics we typically give are Rocephin, azithromycin for general community-acquired pneumonia. So we give lots of O2, right? Oh no! And even then, that's not necessarily wrong. You're not gonna. Technically, the physiology behind it, there's a reason behind it. And the reason is because when a COPDer develops this disease, they become hypercapnic. They increase the amount of CO2 they're retaining. And we have some mechanisms of respiration. We have our conscious respiratory drive, and we have our subconscious respiratory drive. And the subconscious respiratory drive is based on information from the brain. It's based on information from the sinus and carotid arches, as well as the aortic arches, all which have different sensing mechanisms for oxygen level and CO2 level. We're primary CO2 driven breathers, normal people. But eventually that gets blunted because when you have such high CO2 chronically, that sensing mechanism just goes away and it goes to the default, which is O2. So when the caution is that when you give a COPDer 100% oxygen, you're gonna blunt that respiratory drive, because the respiratory drive has now been oxygen driven and not CO2 driven, and they have a ton of CO2 and their oxygen's good. Well, technically they'll not have that intrinsic drive. That doesn't mean they're just going to suddenly stop breathing because they're awake. Now, where this comes into play is like leaving somebody on, or I imagine this, and there's not even really any good case reports that I've found of having a patient die because oxygen was given overnight and that killed the respiratory drive. It's just more so that we know the mechanisms, and this is a possible blunting of that mechanism to have them be able to breathe. So I have no problem with supplemental oxygen goals of 88 to 100%. You're not gonna kill them with oxygen. Then now, and there are physicians who will be blue in the face about this and say that that's absolutely not true. Based on the literature I've read, I'm giving these people oxygen because they suck at perfusing and ventilating. Yeah. And more often than not, they need the oxygen. So I'm not really worried about it. I think this is more of a nuance that an internal medicine doctor would kind of get off on versus emergency services, which is what we are. We're here to treat the condition, save their life, stabilize them, and get them to the appropriate people. Yeah. Right? I'm not. So having said that, it's a common misconception, but there's also true physiologic reason as to why that's a caution. I don't really have any good answer for you besides give your patient air if they look like they need air. Like treat the patient, not numbers, right? Right. So, and this just basically talks about what I talked about. So you shift your normal respiratory drive. So there's the blue bloaters and the pink puffers. That's kind of your two typical COPDers, or the big blue guys with bronchitis, and they trap a little air differently than emphysematous patients, which are cachectic, they're thin, hyperinflated lungs. So two different features. Oh, quiz time.
Oh, lordy.
All right. 55-year-old woman with COPD presents to the emergency department with dyspnea. You guys got equations and quizzes with my lecture.
Yeah.
With dyspnea wheezing for longer than 1 day, she indicates she's been working in a new building, it's been painted, heart rate's a little fast, blood pressure's okay, she's slightly tachypnic, afebrile, room air 97%, speaking of full sentences, but an audible wheeze is heard. How often do we have that, right? Patients just wheezing. Along with albuterol and ipratropium bronchodilator therapy, what medication is indicated at this time? Probably prednisone, right? Steroid. So, 60-year-old, COPD, dyspnea, wheezing, cough, increased sputum production. He's too short of breath to talk to you. He's afebrile, good pressure, he's tachycardic, he's pretty tachypnic, decently tachypnic, and his SpO2 is 80%. Increased work of breathing, poor air movement, he's wheezing everywhere. You give him the Dunem, he's on BiPAP, and he feels better. He's maintaining an O2 of 92%. So what's the most appropriate treatment regimen to administer at this time? Oh, did I put the answer on there?
Is it the one that says your answer?
No, it's not. Okay, good. So let's see. It's just adding on a steroid. It basically is just asking you what haven't we added on. We haven't added on a steroid. We haven't added on antibiotics.
Oh, yeah. Okay.
It's hard to come up with. It's hard to get like a bunch of different COPD questions because they're all very much similar. What do you give? Well, I'm giving Duodenib.
Yeah.
Okay. Well, what are you going to give next? Steroid. Okay.
Yep.
Okay. Say that's not working. Non-invasive ventilation. Right.
Yep.
So next step in management is what this is asking. Non-rebreather, work of breathing, not improving. So 79%. What do you guys think? I gotta read the question actually. I just read it. So I don't have the answer. I'm gonna put on BiPAP or something. Yeah. Oh, it's on a non-rebreather. I misread that. Yeah, so I put him on BiPAP, right? I'm not gonna immediately tube him. I'm gonna escalate. Hopefully, I put an answer on this one. I'm gonna be pimping myself here. Jesus. Okay, good. There is an answer on this one. So, 60-year-old man, history of COPD. Who would have thought? Hypertension presents the ED, shortness of breath, worsening chronic cough. Vital signs show blood pressure is stable, slightly tachypnic. O2 is 84% on his home liter, 2 liters. Heart rate of 105. Normal mentation. He's tachypnic, tachycardic, coarse lung sounds. ABG shows pH 7.3. Somebody who, you guys know much about pHs and that? Do you guys ever read any of that stuff now?
A little bit.
So this is when we're talking about like hypercapnia. This is the ABG is kind of our quintessential. What is the acid base status of the blood? It gives me the most accurate O2 and it gives me a more accurate CO2. But a VBG really can indicate me about blood pH and PCO2. So you don't necessarily need the ABG, but the ABG gives you the PaO2. This is kind of a insight in our world a little bit. So what's going to be the best treatment? Well, start low and slow, right? So titrate them up, 88 to 92. I had a hospitalist yell at me one time about this. I think this is why this has stuck with me so much. I had a hospitalist just chew me like, "What are you trying to kill the patient?" Blah blah blah. And I was like, I don't think so. I'm not trying to kill the patient. So then I went right up on it. I was like, it's not even that. Like, come on. So there's my references. So I know it's a lot. What are the biggest things to take away for you guys in the trucks? Right, you come into a house. Got this really dyspneic, just work breathing, labor. Get them support. It's support, it's support, it's support. Your bronchodilators decreases that airway inflammation. Remember, they're already narrow. When they have an exacerbation, that's inflammation on top of that narrow airway already. And remember, it's to the 4th power. So you decrease that 1-2%, that has a massive impact on their ability to breathe. So they might be, I think a COPD is kind of in a gaming analogy, like a glass cannon, you know. They can easily just get broken. It doesn't take much just to send them down the wrong path. And that's because of their fragile status. They're riding the border of constantly having acidotic blood, having hypercapnic blood, you know, the effects on the heart. So biggest thing for you guys is getting steroids, breathing treatments on right away. Give repeated breathing treatments. You're not going to hurt them by giving them more. Okay, if it's not working, give them more. I don't foresee any reason that if I were to receive a patient from you guys and you're like, "Hey doc, I had to give him 3 breathing treatments," I'm like, "Okay, yeah, great. I'm gonna give him 1 here too." You know. Now there is max dosing and stuff like that, but I don't know. I say treat the patient. Give them the steroids right away. Give them the breathing treatments. Give them the non-invasive ventilation.
Yeah.
So don't be afraid to pull the trigger on that stuff. That's what I got. Thanks for coming though.
Cool. We're giving him a few seconds for questions. You okay with that?
Absolutely.
They're 20-ish seconds behind us, so.
Yeah, just send a message out.
good stuff.
Cool. All right, thanks guys. Thanks for what you guys do. I appreciate you. You guys are, yeah. You guys go through a lot of shit,
Yeah.
to say the least. Sorry, can I say I forget that I'm on the mic.
I killed it a little early.